In previous modules, what we've been discussing is the development of the immune cells that are needed to protect our bodies. And we've talked about their development in the bone marrow, their selection either in the bone marrow or the thymus, and now we're ready to set these mature naive cells, or these virgin cells, out into the body to do the job that they're designed to do. Now, we call them mature and naive because they're not yet battle-hardened. They're prepared to do their job, and yet they've never been asked to do it yet. So if you think strategically at this point, you realize that the uniqueness of each and every receptor on a lymphocyte stipulates that in order to have an effect, it's going to need to go to an area and find its cognate antigen in order to respond to it and have some protective effect. And the problem with that is that a single cell emerging from the primary lymphoid organs, the bone marrow and the thymus, has to go out into the body as a whole and find that needle in a haystack foreign substance that is complementary to its receptor. So when you think about it in those terms of one cell needing to find the source of entry of a foreign substance and do something about it, you realize that you need to have two things happen. You need to have those cells capable of moving through the body and sampling from different locations. And you also need to have a way for them to respond to signaling that is coming in from tissues where injury or damage or invasion has occurred. So in this chapter, we're going to discuss what we call lymphocyte trafficking. In other words, the movement patterns of lymphocytes as they come from the primary lymphoid organs to go out into the body and try to find that thing for which their receptor is specific. Now, as you notice, this brings us to the topic of the discussion of the secondary lymphoid organs. And these organs are designed to be the locations where my mature naive lymphocytes actually meet their specific antigens. And in these locations, these secondary lymphoid organs, they're also designed anatomically so that there can be a maximum amount of crosstalk between the cells and the foreign substance and other collaborative cells which might be necessary to perform a fully fledged immune response. So my secondary lymphoid organs, of course, are my lymph nodes, of which there are hundreds, my spleen, of which I have one, and of course it's the largest secondary lymphoid organ, and then a specialized set of tissues that line the bowel that are designed to sample material coming in from the gastrointestinal tract. And we can call those in general mucosal associated lymphoid tissues, or we can talk about them specifically in the small intestine being the prototypical Peyer's patch. Now, realize that the design of these secondary lymphoid organs is to sample the environment in different locations. The lymph nodes are designed to filter the lymph that drains out of all of the tissues. The spleen is designed to filter the blood, and the Peyer's patches are designed to sample the material in the intestinal contents and determine the difference between things that I need for caloric value versus things which truly could be pathogenic to me. As we think about the lymphocytes moving from the primary lymphoid organs into these secondary lymphoid organs, you need to realize that in addition to their antigen receptors, lymphocytes have broad categories of molecules on their surface which allow them to respond to their environment. Some of these are chemokine receptors, which respond to small chemicals, and these chemical sensations will cause lymphocytes to move along a gradient toward the scent of the area where they were produced. And then additionally, cells will have on their surface adhesion molecules, which are complementary to the surface of another cell that has a complementary receptor, and these will cause brief binding cell to cell and the ability of one cell to move either through the extracellular matrix or out of the circulation into the tissues, etc. Now, other than that, we mentioned the chemokines and the adhesion molecules. Realize that in addition to that, I need to speak with you about the high endothelial venules which exist in the lymph nodes and the Peyer's patches, because these are specialized areas of endothelium where the cells overlap with one another in a more loose fashion in order to allow the fairly easy escape of cells out of that area and into the tissues of the organ. And so in the lymph nodes and the Peyer's patches, lymphocytes will leave the vasculature and go into those secondary lymphoid organs by virtue of those somewhat leaky high endothelial venules. And it is L-selectins on the surface of the lymphocytes, the L standing for lymphocyte, that bind to the complementary addressin molecules on the HEVs. The prototypical addressin molecule, of course, is sialyl Lewis X, and that will cause those cells, once they have responded to the chemical gradient by their chemokine receptors, they are then able to home specifically to particular areas in those organs. So you'll find as we look at the anatomy of the lymph node and spleen that there are specialized locations which come to briefly house the different types of populations of lymphocytes. T cells will go to one area, B cells to another. And the reason for that is because of the differences in their adhesion molecules and their responses to these chemokines. Now, the spleen does not have high endothelial venules, but instead, lymphocytes leave the blood in the spleen by migrating out of the blood sinusoids and into the tissues, into what we call the white pulp. And that process, known as diapedesis, is something that we will speak about in another module coming up as we discuss the topic of inflammation. Now, all of the secondary organs, in addition to having particular areas in which the cells will come to reside, are designed to be sort of speed dating sites so that foreign substances coming into that organ are slowly percolated over the surface of these populations of mature, naive cells. And if the cells recognize their cognate antigen, that sets off a cascade of events of activation and cloning and so forth that we'll speak about in later modules. But the design of each of these organs is such that there can be maximum exposure to foreign substances and maximum ability to collaborate between the different types of cells that are necessary to make a fully fledged immune response. Now, realize that in order for this process to work, I have to hypothesize, and indeed I can prove by radiolabeling, that each mature naive lymphocyte from the primary lymphoid organs is going to have to make circuits of the body looking for this material that binds to its receptor. And the rate of recirculation is truly astronomical when you think about the number of cells in total in the human body. Each lymphocyte will check into every lymph node you own on average once a day, and the spleen every other day. So they are literally coming into these organs, sniffing around for danger, and moving on to the next if they don't find it. If they do sense danger, that sensation being something that bound to their receptor and set off the activation sequence, then they will stay and clone themselves. And of course, the reason clinically that we see lymphadenopathy and splenomegaly being hallmarks of infection is because of the fact that we're simply observing the enlargement of the number of the organ by virtue of the number of the cells that have been cloning themselves in response to the material that has entered. Now, when we look at the architecture of the lymph node, notice that what we have to talk about here is two flows. We have the flow of the lymph into the node, and we have the flow of the blood bringing cells into the node as well. These are sort of against one another, the lymph node itself bringing in the material from the tissue fluids, and the cells being brought in via the blood to sample what is present in the node. As the lymph comes into the node, it, of course, is going to enter through the capsule in afferent lymphatics, so-called, and it will percolate down over layers of cells, showing in sequence first the macrophages that would be found in the superficial sinus on the capsule of the node, and then percolating down over the T cell and B cell areas beneath. Remember that my B lymphocytes, as they respond to the signals that cause them to traffic through the body, they will come to reside in the cortex of the lymph node, and they will make both germinal centers and follicles in the area of the cortex, accumulations of B cells waiting to see the signaling of the antigen entering the node. T cells, as they migrate through their pattern of trafficking, will come to reside in the paracortex. And the paracortex of the node stretches finger-like in between the areas of the cortex so that these areas of communication can be established between T cells and B cells when that is a necessary process. So as the foreign substance comes into the capsule of the node, it first has an opportunity to interact with macrophages. Then, if it is captured by macrophages, they can serve as antigen-presenting cells, as you'll see in a later module. And if it's not caught by macrophages, it still next will filter down over B cell areas. B cells will have a chance to sample to see if it fits their receptor, and then it will filter down to the point of reaching more macrophages in the medullary cords. Now, T cells, you'll come to find, do not see antigen by themselves. They must have it shown to them on the surface of another cell that we refer to as an antigen-presenting cell. But notice in this design anatomically that it could be my B cells in the follicles who present to my T cells in the paracortex, or it could be my macrophages who serve as antigen-presenting cells. But the T cells in their paracortical areas are there in a perfect position to be communicated with in order to make the maximum possible immune response. Now, when we look at the comparison of the design of the spleen, you'll notice that the point of the spleen is that it is going to filter from the blood, but it's a very similar technique of antigen being exposed first to B lymphocytes and to antigen-presenting cells and then to T cells before the rest of the process takes place. Now, notice that when lymph is done passing through a given lymph node, then it, of course, is going to be continuously filtered out of the hilum of that node and into the efferent lymphatics, which will eventually be taken to the thoracic duct, where they will then be drained into the systemic circulation through the left subclavian vein. And the percolation, the filtration, and the movement of lymph is kept in unidirectional fashion by virtue of the fact that lymphatics have valves in them that make it certain that lymph cannot backflow into the area from which it is being drained. Now, looking at the design of the spleen, remember this is an organ that has dual purposes. It not only is going to function in removal of aged red blood cells when necessary, and some red blood cell storage as well, but it has what is called a white pulp, which is the location where I am going to have my lymphocytes do their recirculation when necessary. So all of this area that I have highlighted sort of in a pinkish red would be my red pulp, where I have got a variety of sinusoids lined with phagocytic cells whose design it is to capture things out of the blood. Now realize again, thinking from a strategic point of view, the blood is coursing through your body at the speed of the pumping of your heart. So if I need to capture something by phagocytosis, which is a labor-intensive cell surface to microbial surface engulfment process, realize I need to slow the flow of the blood in order to make that happen as well as it should. And so one of the functions of the spleen is to take a very rapidly coursing channel of blood and move it into a very large diameter, large volume area of sinusoids where I can slow the vascular flow and allow all of those phagocytic cells to have time to capture the things that need to be captured. And this is essential physiologically in order to allow things to be captured out of the blood. Now, around the arterioles in the spleen form the white blood cell areas, which I referred to before as the white pulp. And if you'll notice, as the lymphocytes do their recirculation, as they move to the spleen, again, they move out in areas where they will be attracted by their various chemokine concentrations and adhesion molecules. The T cells will come to reside in the so-called periarteriolar lymphoid sheaths, a very descriptive term. They're right around the arterioles, and the B cells will come to make follicles outside of those regions where they will have accumulations of B cells waiting to sample the area from the blood. Now, other than that, the flow is simply from the blood into the sinusoids and then into the white blood cell areas, or from the blood into the white pulp so that the cells can wait there for the materials to enter from the sinusoids. But the key distinction here is I'm filtering the blood versus in the lymph nodes where I was filtering the lymphatic material. Now, realize that other than that, our mucosal associated lymphoid tissue happens in all mucosal lined areas. So I could talk about the bronchus associated lymphoid tissues, the BALT, I can talk about MALT, I can talk about GALT. Normally, I simply use the term mucosal associated because if you notice, that sort of covers a large category of these types of tissues. But I wanted to speak with you particularly about the Peyer's patches because it is in keeping with our idea of sampling different areas of the body to look for invasion, that you have to remember that the Peyer's patches are basically areas where I do not have incoming lymphatics, but instead they are filtering material from the gastrointestinal contents and bringing it in that way. Now, a very important cell known as the M cell actually operates in between the villus cells in the intestine. And M cells are unique because they do not have mucus on their surface, nor do they have villi. And yet their design is to sample by endocytosis and to produce vesicles of material, which are then released internally into a bed of waiting lymphocytes for sampling. So instead of sampling lymph or blood, they're sampling the gastrointestinal contents. Now, over a lifetime, what will happen in the Peyer's patches, and indeed in any of the mucosal associated lymphoid tissues, is that these areas will become populated with memory cells who have recognized their antigen in one of such of these locations and has now specialized its expression of chemokine receptors and adhesion molecules so that it constantly patrols only those areas that are similar to those in which it first experienced its cognate antigen. In other words, it should make sense to you, I think, that if a pathogen got into my body yesterday by my having breathed it in, then it's not likely that that pathogen with its own life cycle is going to decide to try and get into my body tomorrow through my big toe. Pathogens have life cycles and mechanisms of entering the body so that your immune response has to learn where those locations are and then specialize the cells that it has in order to recognize the invasion at that point. And this is done by the differential expression of those chemokine receptors and adhesion molecules so that they will then patrol specifically those areas of the body where it's necessary to protect. You're basically moving your army to the area that is most easily defended, which is the point of entry of the pathogen. Now, once again, we're going to play a little game here that I call Make Me Care. Realize that sometimes immunology seems awfully esoteric, and yet your understanding of how this system works is absolutely essential for being able to explain to a patient what it is that is happening in their body that's perfectly normal as a response to invasion, and what are those things that we need to be concerned about. Well, realize that the description of Virchow's node is a very famous one historically in pathology, because very early on it was discovered that an enlargement of that node, which is supraclavicular and is palpable in some cases when it has enlarged, that the finding of enlargement of that node, which is called Croisier's sign, is a sign of an advanced malignancy. Now, I want you to think through what you know about lymphatic system drainage and think about why that would be true. And then we're going to come back after you pause your video, and we're going to walk through that in a moment because it reinforces your understanding of how lymph moves through the body. I hope you've taken time to think about this now, because realize Virchow's node is found very close to where the thoracic duct drains into the left subclavian. And so any lymph being drained from lower portions of the body is going to be moved up through that valvulated system to the thoracic duct and put in that region. So if I have an enlargement of that node, it reflects the fact that I have got cellular proliferation in the area. And if I have a malignancy that has occurred almost anywhere through the gastrointestinal tract, the first sentinel node that I would be able to look at easily in order to determine that there has been metastasis is going to be this one. Readily available, readily biopsied, readily interpreted to see if I've got metastasis. And realize metastasis is a sign of an advanced malignancy, and so this would be a poor prognostic indicator for the patient. Our next question. Patients who have been either naturally splenectomized, patients who have sickle cell anemia, or patients who have had trauma or have had some other condition that required them for clinical purposes to be surgically splenectomized, these patients, before they even leave the hospital, in the case of the surgical removal of the spleen, will require special vaccine protocols in order to protect them from things that they otherwise, when they possessed a spleen, would not have had trouble managing. So, can you explain why this would be so, and why in particular it would be the encapsulated microbes that would be a problem to a patient who has lost their spleen? So pause your video and think this through, and then when you're done, we'll come back. Well, if you remember our discussion of the spleen, it's true that the spleen filters the blood. And one of the reasons why the spleen is so necessary physiologically is to slow the flow of blood so that the macrophages lining the sinusoids have a chance to interact with anything in the blood and engulf them. So this is naturally very important for any blood-borne microbe. But if I add on top of that the microbe in question has a slippery surface that makes it difficult for a phagocyte to grab onto it and engulf it, then I think you can realize that the spleen now becomes absolutely critical because of the fact that the phagocytes, like neutrophils in the blood, would not be able to capture something that slippery in the normal flow of blood. It would be like trying to hold on to a bar of soap in your shower. The slipperiness makes it almost impossible. So without a spleen, encapsulated microbes become a terrific problem. And so we institute a vaccination protocol that will protect these people in the absence of a spleen to make the antibodies necessary so that those antibodies can both perhaps activate complement and also serve as opsonins, things that coat a microbe and allow it to be more easily grabbed onto and held. Okay? Opsonization, if you recall, is the process of coating a particle with either an antibody or complement in order to make it more easily engulfed by phagocytosis.